And now I want to invite Captain Jason Piotrowski to join me. Now, Captain Piotrowski began his career in law enforcement in 1995 as a local police officer before joining the New Jersey State Police in 2001. Jason served as a general duty road trooper before being selected as an initial member of the State Fusion Center of the New Jersey State Fusion Center in 2006. Jason represented the state of New Jersey at the National Operations Center in Washington, D.C., where he served multiple tours. 2014, Jason was selected to help develop the New Jersey Drug Monitoring Initiative, which was based on a multidisciplinary approach that included public health, public safety, government and community leaders, treatment, prevention, and recovery stakeholders. This group ultimately came together to mitigate community drug harm. Currently, JP supervises the Office of Drug Monitoring and Analysis, where he oversees collection, analysis, intelligence production, training, and outreach efforts related to the drug environment, specifically focused on the overdose epidemic. Jason is also a Bloomberg American Health Initiative Fellow and is working towards his master's in a master's in public health candidate at Johns Hopkins University. He is focusing on overdose, addiction, and health disparities. He was our guest speaker at our plenary speaker at our law enforcement summit last week. I was so impressed with the outcomes of New Jersey. Spoiler alert, New Jersey's overdose death rates are going down, and the work that coalitions or task forces like Jason's are doing are directly contributing to the positive outcomes they're seeing. So please join me in welcoming Captain Piotrowski to the stage. Thank you for joining us today, JP. And you are on mute, my friend. Come on.
There we go. I'm an amateur. No, thank you so much for having me. I really enjoyed coming down there, and I came down a few days early, and I brought my family. I'll just share this with you. I have a teenage daughter who, after a couple of days came up to me and said, "Why is everyone being so nice to us?" And she couldn't understand it. And I said, "Well, we're from New Jersey. It's a little different up there." And so anyway, just for the hospitality from everyone down there, we were in Clearwater and Tampa, obviously. It's just so nice and refreshing to be around such nice people. But yeah, I just wanted to share that with you. Thank you for having me. And I'm going to jump right in and share my screen here. All right, so are you seeing the presentation view?
Yes. No, we don't see it in presentation view. Now we do.
Okay. And then I'm going to take myself off video just to shave some bandwidth here. So this is really what the talk's going to be about. It's how we built our partnerships to reduce overdoses. We shared a lot of data, resources, and intelligence. And the spoiler alert, yeah, we have some successful outcomes in the end here. But it has certainly been a long journey. I've been with our drug monitoring initiative for about a decade now, for 10 years. And I'm going to set the stage a little bit of what New Jersey looks like. And you can see down there in 2012, overdose deaths had been increasing before that, obviously, due to oxycodone. And this is kind of really where the heroin transition occurred there in 2012 and 2013. And we were asked, the New Jersey State Police was asked by our Attorney General's office, what we knew about this, really the oxycodone and heroin epidemic and what we could do about it. And so we really didn't have a lot of great answers at the time. And you can see here over time, overdose deaths increased pretty significantly up to about 8 per day in New Jersey. And that's how many people we were losing from about 2018 to 2021. And those 2021 numbers will come down a little bit. Generally, what happens by the time the state chief medical examiner goes through all the data, they'll come down a little bit. But I'll get to 2022 and 2023 a little later. So what are we up against here? I mean, we have, you can see there on the left, that's samples testing for heroin only. And again, I just mentioned that we were dealing with a heroin epidemic, and now heroin only, you almost never see it. And certainly the chart on the right there is shows how much fentanyl is in the samples that are received by law enforcement. Xylazine, that's another threat we're facing right now. In 2022, it looks like it went down. It really didn't go down. Overall seizures went down. The percent in the drug environment actually increased slightly in 2022, as you can see in the chart below. But again, that 240,000 there in 2021 is 240,000 individual bags of heroin or fentanyl with xylazine in them. So certainly a lot is being seized, and we're seeing that in our drug environment. Nitazines, another new threat that's out there, and we're seeing significant increases year over year, and we expect to see more, and we expect to see this rising. And then for us, methamphetamine, if you look in 2015, we were getting about 200 cases a year. Now we're up 1,500, 1,400 cases a year. The interesting thing about this, and I did mention this the other day, and apologies to anyone who saw me the other day because it's going to seem a little redundant, but the methamphetamine cases, one of the cartels, we had intelligence in 2013, 2014 that they were trying to build a methamphetamine market in New Jersey. It had never been much of a drug of choice in New Jersey, but they felt we were going to legalize marijuana, and they wanted to protect their business model, and they were going to create a methamphetamine market. And it looks like they knew exactly what they were doing, because they did create a methamphetamine market, and we did legalize marijuana several years later. So the one thing I do is I talk about stigma, and Sean mentioned this before, how important it is. And so the reason I do it is because as police officers, coming from my perspective, because we enforce the law, and this is just, what I believe to be true, many people believe that we're judging people because we're enforcing the law, and that creates a barrier between us and the people that we serve in the sectors that we need to collaborate with. And also, we want to dispel the notion that drug use is merely a moral failing. And again, I'm echoing what Sean said there. Coming from police who were often looked up to as leaders in the community can be powerful and impactful as well. So we look at some of the factors that lead to SUD in adulthood, and we have this common ground in understanding that we're dealing with a disease here. So I often present this when I'm out there, especially to law enforcement audiences. But it's good for everyone to show that we do kind of have an understanding of this as well. So these are all several studies, scientific studies that were done that show the correlation between genetic predispositions and substance use disorder. And I'm not going to go too deep into this. We also talk about military service and substance use disorder, and you'll see a common trend here. But these are several different studies that show that our veterans have increased rates of substance use disorder compared to the general public. And I talk about ACEs a lot, so adverse childhood experiences. And this is really important. And I didn't talk so much about this, but ACEs are household dysfunction. It could be loss of a loved one. It could be divorce. It could be substance use in the home is one. Obviously, emotional, physical, sexual abuse. So, but again, we're talking about trauma, and the same as we were talking about with veterans is whatever with PTSD, and we're talking about ACEs, and again, the common thread there is trauma, and then the correlations to substance use disorder. This is the study that I talk about mostly, and this is Doobie et al. In 2003, and they interviewed about 8,000 people in their 50s. and they asked him, have you ever had a drug problem? And have you ever been addicted to drugs, and have you ever injected drugs? And if you look at the disparity there from 0 ACEs to 5+ ACEs, you get an 823% increase in ever had a drug problem, 1,050% drug increase in ever addicted to drugs, and then a 1,333% increase in ever injected drugs. And again, why this is important is and I didn't mention this the other day, but we're talking about this ACEs, and you see that just incredibly strong correlations to substance use disorder in adulthood. And we're talking about the people we're trying to help now, but that's going to be cyclical. And so now there's children in the home now that have this household dysfunction, that may witness an overdose, that may lose a parent, they have substance use in the home. Certainly there could be divorce and things like that. So frankly, how well we get a hold of this problem now is going to pay dividends for our children and our grandchildren in the future, because again, these things are linked long term. And we really want to kind of do our best now to combat this problem so our children don't have to. And that's one of the things that I didn't mention the other day, but it's just one of the ways I view this. So the presentations that we've given this presentation, similar presentations about this DMI capability, about building multi-sector collaborations, and about how we're kind of understanding the drug environment and sharing that information and kind of developing these positive outcomes. So we've had several other countries and many states have asked for briefings from us. I think about 8 or 9 states have started DMI programs that we've kind of mentored them through as well. So what is a DMI program? We start with robust data collection, and we analyze information. We develop forensic intelligence, and we identify emerging threats. And the example I'll give is fentanyl in 2015. You saw those graphs earlier. We were able to brief the media and our government leaders that we felt that fentanyl was going to take over for heroin, and we put that out in 2015. We put our first xylazine release out in 2016. Aggressive and proactive information sharing and intelligence sharing. So from a law enforcement perspective, we develop intelligence. We collect data, we analyze the data, we develop intelligence, and in this case, forensic intelligence, and using our criminal forensic labs. And the one really great thing about that is you don't have to survey every police department, because all the police departments submit their information to these criminal forensic labs. And if you can pull that data from there, it makes data collection so much easier. And that's what we did in New Jersey. And with that, we were able to, again, develop that law enforcement intelligence, but we shared it with our public health partners, harm reduction, treatment, prevention, Department of Health, Governor's Council on Alcoholism and Drug Abuse, so that they could use that information and help serve their communities better, help serve their clients better. And that was one thing that we did. And again, reimagining our public safety role, incorporating best practices that we learned from our harm reduction folks, our prevention, treatment, and public health folks as part of that partnership. Our data sets here, we have a lot of data sets that we used. I'm not going to spend a lot of time here, but we have millions of data sets that we use to develop our intelligence and build our reports and share those out. I'm going to spend a little bit of time talking about ODMAP. So overdose detection mapping application program. The first great thing about this is it's free. And the second great thing about it helps us to really understand the drug environment in near real time and mitigate it and stop people from dying. And I'll show you some specific examples later on. So again, developing crucial insights. This is in the red there, that's what the media covered. We're talking about heroin today, but we're going to be talking about fentanyl tomorrow, and that was November 2015. What was really great about when we developed these crucial insights, it gave us a lot of credibility I wish that was more impactful when we were talking about fentanyl in the beginning, but it wasn't. But what it did, you can see we're talking about xylazine in 2016 and in 2019 and again in 2020, long before it became a big issue. It gave us a lot of credibility, and it wanted sharing that information out and pushing it out, and good information and good intelligence. It gave some momentum for our program and allowed other people to kind of understand what we were seeing, and they wanted now to collaborate us and work with us. They realized our information was valuable to their missions. So again, sharing that information had people coming to our door to work with us. More crucial insights, and these are real important. And this is why OD map data is so important too. Understanding the changing demographics. We've seen a big change in our demographics that are affected, and the Black population specifically is much more affected than they were in the past. Again, they represent about 12% of our population, but in 2022 it was 28% of the drug-related deaths and 32% of the naloxone administrations. So again, disproportionately represented in our overdose data, and the age as well. We're seeing a lot of older people, and if we were to break it down very specifically, are we seeing older Black men? 100%. Older Black men are being more affected now than they ever were in the past, and that's an important insight that we, as the state, needed to develop and share that out. Another one here is, again, OD map data. Now cops at the scene, officers at the scene, they know what they're looking at. They're experts in this. So what we do is we collect their perception of the drugs at the scene of the overdose, and that red line there shows fentanyl and heroin. It's reports of fentanyl and heroin at the scene, and those bars show cocaine, crack, and methamphetamine. And you can see those bars getting bigger over time and taller over time, and the fentanyl, heroin getting going down. And you can see kind of now they're on different scales, certainly, but you can see how the cocaine and has overtaken the fentanyl reports from the officers at the scene. And again, this is a trend, and it's a real important trend to see, and it all kind of ties together. What we're seeing is more cocaine, methamphetamine, and crack being involved in overdose deaths. And really what's happening is people who their drug of choice happens to be those stimulants, there's fentanyl involved. And essentially people are getting poisoned, right? So that's really what's happening there. That report on the left is a press release from the DEA in April of 2022. And you can see that 7 incidents and 29 were fatal. 6 of the 7 incidents thought to be crack cocaine or methamphetamine, and they all contain fentanyl, right? So that's a big trend we're seeing right now. And if you can get a handle on that, you can really get a handle on your overdoses. So this is what's really important here. Continually identify and engage key stakeholders. I can't stress how important that is. I didn't think that was a key point when I started doing this, but over time, people move on and they retire, unfortunately. And you're going to have to continue to develop these relationships with your partner agencies and find the people in those agencies who are willing to work together. It's not always everybody, and it's not always easy, but I found that, with public health and public safety, we don't always see eye to eye on things, and we have different ways of going about things, even though we have a common mission. I found the one thing I'll say is I find really good people in every agency that is willing to work together, because they're mission driven and that they have the same goals as we do, is kind of protecting people and helping people through this and serving the public. So what happened with all that, with developing all those crucial insights and sharing the information, our New Jersey Health and Prevention, our New Jersey Prevention Coalition came to us, along with our Governor's Council on Alcohol and Drug Abuse, our Department of Health, our Department of Human Services, and harm reduction people. They asked for a meeting with us at our State Fusion Center, where we're housed. And what they said was, the information you're putting out is always so valuable. Can we formalize it? And so we started a once a month meeting, virtual meeting. We were doing through the His and Connect program, Homeland Security Information Network. We were on that network. We're doing a monthly call. We've done it ever since. We've done it for many years now. But basically, as the meeting's going on, we think it's a collaboration meeting and sharing how we're going to share resources, and everything was kind of looked like the state police was bulldozing and kind of taking over. And I said, listen, I don't, this doesn't need to be all about us. And I just kind of was trying to not take over the whole thing and run the whole thing, but it just kept going that way organically. And the other people in the room said, no. You've made it very clear that you guys are the leaders in this, and we need you to lead this. And I thought that was really interesting. They're like, we want you to lead this. You guys are doing tremendous work. You have all this valuable information and data from a law enforcement perspective, and we need you to take the lead role in this. We want you to lead it. They're like, you have more offered of this to us than we do to you. And so that was really interesting. And again, that chart there shows how diverse it is from law enforcement, health and treatment, prevention, and the forensic sciences. That's the participation by sector there. Key partners, and what this really means, these are partners, and they run the gamut from universities to outreach to treatment facilities, you name it. But it's really people, and I think this is the most important point, that have a common mission, have common goals. We're trying to stop people from dying. We're trying to get people better, families better, communities better, and we're all working to that common goal. And as long as we have that common goal in mind, and we remember that we have that common goal, I think we can work together. But we have LEAD there, Law Enforcement Against Drugs. We have our Attorney General's office. We have Robert Wood Johnson Medical School, and all the federal partners, of course, that we work with, the health systems. But these are the partners that we've been working with. There's many more. We stopped adding to this, years ago, so it's just kind of a visual. But these are some of our partners that we work with. And again, we have 6,800 people so far on our distribution list across, law enforcement, forensic sciences, and health sector personnel. So now we'll get into the takeaways here. So we've, built these capabilities in the trusted partnerships, and we developed this optimized capacity. So now what? In 2022, so again, from 2018 to 2021, we basically held the line at about 8 per day, give or take. And again, every one of those, I have to say this sometimes, I'm speaking in numbers, and we kind of recognize that it's not statistics, it's really people. And but we've lost 8 people every day from that time. But from 2018 forward, we basically held the line. And then we started going down in 2022. That's about a 7.5% increase. And as of September 30th, you can see where we're at, where we're projected. That's going to be our lowest total since 2016. And it's going to be a little bit better. We had a really good November. So I think we only had you can see that average per month there of 219. I think we were about 180 in November. So that's actually going to go down a little bit. We're going to see another 8 or 9% decrease on top of a 7.5% decrease. So again, I would say from 2018 forward, we've been doing pretty well. We've stopped the significant increases, and we're going down now. And it's no specific credit to anyone in particular. It's a lot of different factors and people working together and sharing data and information and resources. So again, I showed this slide before, but what are the potential benefits from doing all this? Certainly harm reduction in healthier communities, and you could go on and on with this. I was just throwing some bullet points off there. Lower health insurance costs. When people overdose and go to the hospital and they don't have health insurance, that gets pushed onto everybody. Less calls for service for our personnel, whether it's EMS, law enforcement. We can be out there doing other things and better things for our communities. Again, so we have a lot of incentive to kind of work towards this and help our people get into treatment and get better. So these are all the different ways that public safety is supporting harm reduction. We have drug environment awareness we're pushing out, investigative support of bad batches of drugs and bad batch mitigation. I'll get over what our armed report is in a minute. Biosurveillance, outreach and training, and drug content awareness. So I'm going to do a few slides here, and this is really like what we're doing, right? So OD map, spike alerts. So again, we have 10,000 users in the state of New Jersey, mostly law enforcement, but we also have a DUA with our Department of Health. So every EMS or paramedic naloxone administration and every law enforcement naloxone administration goes into OD map in near real time. And so we can understand when there's a spike in drug overdoses. OD map has a built-in algorithm. If it's 2 standard deviations above the rolling average of the last few months, we'll get a notification 24/7. I have detectives monitoring this, and they'll get pushed right to us, and we'll jump on it right away, and we'll see if there's a bad batch of drugs out there, and then we can stop it. And that's really, and we've done that several times. Another thing you can do, you can use that data from OD map and see where your hotspots are and do a hotspot area outreach. And we do this constantly. We send teams out there. We share the information with other outreach teams out there who are not law enforcement. And we say, here's where the hotspots are. There was a spike here. There's a hotspot here, whether it's a quick spike, 24-hour spike, or whether it's a prolonged hotspot. And we will share that information out to our partners so they can go out there and do some outreach. We got an OD map report, and this was, you see that's March of 2022, and it was a few days before that April 22 DEA report came out. We had the same exact thing happen. We had crack cocaine laced with fentanyl, and over a 2-day period, we had 6 fatal and 7 non-fatal overdoses. Again, this was kind of mentioned before, when people have a low tolerance, whether it's due to incarceration or rehabilitation, and they get out, they have a lower tolerance, and it's certainly at higher risk. And a lot of people who do not use fentanyl and their drug of choice happens to be stimulants, they are going to be at such an increased risk. And so when this does happen, it's very dangerous. And we were able to stop that one pretty quickly. The armed report. So this is something we do with OD map that's a little different. We use the Case Explorer add-in with that. We collect all the PII. That's why we're able to see those demographic trends so clearly in overdose. But it's also why we're able to see exactly who is overdosing and who is at risk. And so what we do is we push that information out to who can see it, law enforcement outreach teams in the vicinity. And they will go out and knock on doors and offer help to people. And that's been really impactful for both the community and both the police officers who feel like, and I'll just be very honest with this, I won't get too in deep with the scenario, but there was the first time it was done and it was organized, there were a lot of eye rolls from the law enforcement officers who were like, what are we doing and why are we doing this? And a complete 180 by the end of the day, because the people that they were talking to were so grateful that someone was knocking on their door offering to help them or their loved one with this issue they were going through. So by the end of the day, the reports were, some of the police officers were like, well, this turned out to be one of the best days I've had in my career, because they really felt like they were helping people. Operation Rise. We have a lot of grant funding in our program. We have the Anti-Heroin Task Force grant. Again, we're a state, so we're going to get a larger award. We're $3 to $4 million a year there. But we also received a CARA grant from SAMHSA, and this one gives us about $800,000 a year for 4 years. We were hired peer recovery advocates into the state police on contract, and when we proactively identify someone who has an issue, any trooper identifies someone who may have an issue, may need help, it may be a arrest situation, it may not be a arrest situation. We have recovery coaches who will respond and try to help them navigate those barriers to care and get into treatment and get help. And we've had many transports. I think we're up to we've only been doing this since June, but we're up to 70 or 80 transports of people who wanted help and had troopers driving them into treatment, troopers picking them up at treatment, driving them to sober living. But certainly, we've helped out a number of people so far, and we're just going to keep building on this. We're only in South Jersey. It's a 3-year plan to get the entire state covered. This is another slide on that. I won't belabor that. And I'm getting near the end here. So one of the counties that we work with and what I'm going to talk about here is just this increased engagement and then what the outcomes were there. So the Ocean County Health Department, they started their overdose fatality review in January of 2018, and they invited the New Jersey State Police in. And in August of 2020, we were doing a decedent review, and the state police offered that, your county was an overdose spike at the time of that person's overdose, and basically indicative of a bad batch of drugs. And that started a conversation. And we had this capability at the state level, and this health department was saying, well, what is ODMAP, or what is a spike? Where do you getting your data from? So we were able to give this local health department access to ODMAP. And with that, they enriched it with other data, epicenter data and collateral data from providers. And they were able to develop their response plan. And they took it and ran with it, tier 1, tier 2, tier 3 responses. And their outcomes have been amazing, that I'll get to in a minute. Here's one more outcome. And this is by getting that PII, by getting the data and the people, identifying the specific people. One of our analysts was looking at the data and said, I've seen this name a few times, and they looked at it and they've seen it quite a few times. So we sent an email over to the Burlington County Prosecutor's Office, and we had a very nice thank you back. And essentially that's the email, and I blocked out the person's name, but he was suffering a recent loss of a loved one and was very vulnerable. It had not come to their attention, but because we proactively intervened, they made contact with him, and he was very receptive to their intervention and entered recovery services. So that's something that we were able to make an individual impact on one person. Back to Ocean County. But how does that look? Widespread. I told you about this kind of enhanced engagement. Ocean County, if you look across there, is down 23% from 21 to 22. Again, they're one of the most proactive counties. While the state was down 7%, they were down, again, 23%. And they had the biggest difference there of 56 less people. So again, it's just an example of when we're really collaborating at a high level, and we're sharing a lot of information and resources. And really what we were doing business as normal with the state police, but we were just sharing our business with this local health department. It was so much more impactful for them. And again, 56 people less is a very big difference. That's the biggest total number. It's not the biggest percentage number that year, but it's the biggest total number down. And they built upon that in 2023 as well. They weren't down quite as much, but it wasn't an anomaly. They're down another about 4 or 5% this year compared to last year. So again, good things are kind of happening. Now, if you look at that 7% and you look at those numbers there, I talked about the demographic issues before. If we really looked at by demographics, the differences are a lot greater. So in Atlantic and in Essex and in Camden, where we're seeing increases, there's going to be a more Black population there who's being kind of disproportionately represented now in overdoses compared to where they were in the past. And so again, that's just something that and this slide is going to talk a little bit more about that. You really have to understand those changing demographics, because you have to understand who's the most afflicted people, where your resources are going to be best spent to save the most amount of lives, because we know we can't save everyone. We know we have limited resources, limited time. So where are we going to be most impactful, and how are we going to drive those numbers down? So again, I would just urge you to collect that data, share that data, and allocate those resources appropriately to have the greatest impact in your communities. This is I think this is my second to last slide. Again, that just shows the national numbers kind of going up dramatically and us kind of going down. And I just wanted to and kind of drive that home that we're being very proactive here with our collaborative relationships and sharing information. It's paying dividends. These are a couple of resources I'll share. CDC put out this FAST guide, public health and safety teams, fast.org, how to work together to address the overdose crisis. I think it's pretty good. And these have nothing to do with me, by the way. And PTAC, it has some really great resources. It's Police Treatment and Community Collaborative. There's a lot of good educational resources out there about SUD and about naloxone and how to do outreach and things like that. Again, I have no vested interest in these, but there are some good resources. And that's all I have for you.
Jason, thank you so much. I'm very inspired by your presentation and by the hope that I think is contained within for, the long-term outcomes of intentional partnering and coming together. Does anybody have any questions for Captain Piotrowski? If you do, you can either raise your hand, your virtual hand, or take yourself off mute, or put it in the chat. What I have a question about, our individual counties tend to do really well in terms of data sharing, law enforcement, the medical examiner, behavioral health providers. We don't have a state apparatus that is anywhere near as robust as New Jersey. And so I'm wondering, what if so then that's an additional step that our counties would need to do. And what we're starting to see, and why Live Tampa Bay exists, is that we realize that we need a regional approach. It can't just be county specific. The folks who are carrying the fentanyl don't stop because they've suddenly entered Pasco County. They're going to continue into Pasco. People looking for help aren't just going to look for treatment facilities in Manatee or beds in Manatee. They're going to go outside of Manatee if the beds are full. So what are some of the things that you think are most important in terms of data points and sharing that could increase that really have an impact on y'all's outcomes?
So definitely the OD map data, and I use this analogy a lot with OD map. And I did a whole presentation. I didn't put it in here, but for part of our engagement with the Ocean County Fatality Review Team, during one of the meetings, I gave a naloxone presentation and said, all right, here's your residents who overdosed in Ocean County, and here's where your residents overdosed outside of Ocean County. And you could see these clear trends of female Ocean County residents going down to Atlantic City and Atlantic County were overdosing down there in Atlantic City in the casinos or whatever. And you could see males going north into Monmouth County to Asbury Park, home of Bruce Springsteen. And so you could see these trends, but they had no idea. And so we could see it at the state level, and we could tell them. And I use myself all the time. I live in Ocean County, which is by the shore. I'm a former where Jersey Shore was, that
Yes.
show. It's my first police department. If you weren't at the meeting the other day, I could tell some anecdotes about that. But anyway, I drive across the state into Mercer County. So if I have a problem and it's something that's after work, I go somewhere and I have a friend and I end up using Mercer County. You could run into me every day in Ocean County and not know that I'm really struggling with something, I need help, and I'm at risk of overdose. So I kind of use myself as an example sometimes because I cross the state all the time. But again, so that OD map data is really important to kind of understand, from a regional, I don't know if you would do it from the state level. New Florida's so much bigger. New Jersey, that's an advantage we have, but certainly that overdose data, understanding where your residents are overdosing and the trends behind that. I think that's probably the most important one, is really that overdose data. And Someone mentioned AIDS earlier, and when someone asked me once, he's a clinician who worked on AIDS drugs years ago, and he said, "Well, what would you do?" And I said, "Well, first thing you got to do is you got to stop people from dying. Then you got to stop new initiates into the environment." And and I kind of laid out just off the top of my head. We were just having a conversation, and he said, "It sounds a lot like the plan with AIDS. All right, let's stop people from dying first of all. Let's give people the protection they need, and let's stop people from developing it in the first place, right? So the prevention end. But so again, I think it just goes back to that overdose data. We got to get a handle on harm reduction, and harm reduction is going to change a little bit if you guys are getting xylazine. So harm reduction is
Right.
going to mean wound care, and if you're giving harm reduction kits out, you want to have something, especially for people who are homeless or people who are reluctant to go into the hospital. You're going to want a lot of focus on the wound care there.
I really appreciate that. It looks like, and I think, not all of our counties use ODMAP, and I know that there was some mention when you were talking about spikes, overdose spikes and heat zones, that those who are doing street outreach, those who are doing harm reduction, um, thought that that would be particularly helpful. And yeah, we are seeing xylazine wounds in the field in the Tampa Bay area, and it does make it more complicated, and it does make it important to provide groups like Florida Harm Reduction Collaborative with wound care kits so that they can meet the need. Well, I wanna thank you for your time and for presenting here today. Uh, we learn Florida's big, and yet it's still very helpful and sometimes easier to learn from those who are outside of the state and contrast what we do with what others do in order to wrap our arms around this issue and to improve our outcomes and our practices and our outcomes here in the state. So I want to thank you for joining us today. And if everyone can join me in giving JP, Captain Piotrowski, a virtual applause, I would appreciate it.